Now we will be discussing some questions from again RCPCH website, and then these are all specimen papers or model questions for students to get some idea about how does the exam look like, what kind of composition is the exam, and how should I prepare, what is the level of knowledge that they are testing in us. Right, so if we go to the paper, this is the paper, MRCPCH AKP question discussion, right? So this is session 1, right? Okay, so we will go through some questions. There are 50 questions in this document, but we will not discuss all 50. Time to time, I might skip depending on how lengthy the question is. Right, now, question number 1. Right, cardiology. Boy of 12 years with a 5-year history of chest pain occurring 2 to 3 times a month and pain at any time, and is not particularly related to exertion. He describes the pain as sharp stabbing pain localized to left anterior chest wall, which lasts for a few seconds. There are no associated symptoms, although he is rather anxious with increased heart rate after the attack of the pain. He has a normal exercise tolerance. Examination is normal. Right. Select one answer only. This is how MRCPCH questions are worded. So what is that one answer? Is that asthma, osteochondritis, myocardial ischemia, pneumothorax, precordial patch syndrome? Right. Precordial patch syndrome. Right. Now, what do we think as the answer? Now here, because we have 2 minutes or 2.5 minutes per question, we have to be really fast, right? We don't have time to analyze a paper or question for a long time and then come to a critical decision. No, we can't do that. We need to skim through questions, but we need to make sure that we don't miss important information, and very fast we need to come to a diagnosis, right? Okay, now one way to answer or find out the answer is, of course, you will go through the question and then you confirm, okay, this is the answer due to this reason. The other way is you remove, right? You can eliminate the answers which are wrong, then you might come to the correct answer or most likely answer. Then you read around the question and see if that most likely answer is matching with the scenario. Right. Okay, now if you check this one, asthma, right? Asthma. Now the question is, could asthma go on for 5 years? Yes, right? Asthma could last for 5 years. Sometimes some children can have asthma lifelong, right? However, in asthma, do you get sharp stabbing type pain located to anterior chest wall? Now you see, it's more of a localized pain. You know, asthma is a systemic disease, and it's very unlikely for them to get localized pain due to asthma. So that is unlikely. Also, if it is asthma, child usually have some other clinical features. They might say there is exercise intolerance, seasonal variation, right? So nothing such is mentioned. And here it says examination is normal. Normal exercise tolerance. When you have normal exercise tolerance, it's very unlikely that this child has a significant respiratory or cardiac pathology as the underlying diagnosis. And then it also says that examination is normal. If it is acute wheezing causing this kind of symptoms, we expect child to have bilateral bronchi, reduced air entry, some of these, right? So none of them is there. Costochondritis. Now, costochondritis is fairly a benign condition, right? Where there is an inflammation in costochondria on that cartilage area. So their examination could be otherwise normal, except they might have some localized tenderness, right? Localized tenderness. Here, there is no tenderness mentioned. Therefore, it's unlikely that it is costochondritis. Also, it's very unlikely for costochondritis to go on for 5 years, right? So it will occur, that inflammation, and then it settles. Right? So that's unlikely. Myocardial ischemia is again unlikely. They can have sharp stabbing type pain like myocardial infarction, but it's very uncommon myocardial infarction to go on for 5 years, right? Myocardial infarction going on for 5 years is very unlikely. If that was the case, by now child should be in heart failure due to significant ischemia. If that was the case, we expect child to have exercise intolerance as well, right? So that again is out. Pneumothorax, obviously we know pneumothorax will not last for 5 years, right? Either pneumothorax will um, resolve by its own if they are small pneumothoraces, or if the pneumothorax was very large, somebody must have drained it, right? Or it would rupture. So one of those would happen, right? It's very unlikely for a child to live with pneumothorax for 5 years. So that's unlikely. Number two, if this was pneumothorax, we expect child to have reduced air entry to that side. There will be hyperresonant percussion note. Trachea could be deviated to the opposite side depending on the size of pneumothorax, right? Here nothing is mentioned, so that is unlikely, right? So then what is the answer? This is precordial catch syndrome. So this is a fairly benign condition. So they will present just like what is explained here, right? So they will present with episodic pain and they will be very sharp and could be located to one side. Usually, we might give some pain relief, but otherwise, reassurance would be fine. We don't have to do any specific treatment for this, right? So here, what they tested was to see if we know how to evaluate children with respiratory problems and how to evaluate chest pains, right? So this question might come in a different way, right? Examiners might change the wordings and then they can make it to a completely different question. Say instead of 5 years, if they say 5 days history of chest pain, right, with associated exercise intolerance, right, then it is very likely associated exercise intolerance, 5 days history of pain, and sharp stabbing type, then somebody might have to think about myocardial ischemia. Or if they say the pain is ongoing for 1 month, intermittent, and it is more in the evening upon exposure to dust or smoke, right? And then child was also found to have bilateral wheezing upon auscultation, then you know that he is talking about asthma, right? So this is the first question that we are doing. We did. So this is to get an idea how this AKP questions would appear. Right. Next question. Please give a try. Right. Okay. A boy of 15 years presented as an emergency with a 1 week history of chest pain. The pain first started when playing football. He also complained of headache and neck stiffness. The pain is localized to left precordium and described as aching pain aggravated by exercise. He vomited twice on the day before presentation. On examination, temperature is 38, pulse rate 72, blood pressure 130/85. Mild neck stiffness was noted. Heart sounds are normal with no murmurs. ECG, sinus rhythm, ST elevation in inferolateral leads. What is the underlying diagnosis? Underlying diagnosis. Right. Right now, this time, there is a history of chest pain, and they also give some examination findings, but this is very important. Sinus rhythm, ST elevation in inferolateral leads. Right? So there is ST elevation. Right? So what does this indicate? There is significant cardiac pathology is going on. Right? Significant cardiac pathology is going on. That is why he has got ECG changes. Right? So because of this, when we read this question, we need to make sure that our differential diagnosis are narrowed down to cardiac causes, right? Cardiac causes, right? Also, what information in the history favors that it is something to do with cardiac? You see, the pain started while playing football. So this is something which was aggravated by exercise, right? Also, he has vomited twice. So this could be something to do with sympathetic activity, which we get in severe pain and especially myocardial involvement, right? And this is aching pain and aggravated by exercise, right? So exercise-induced chest pain, right? Exercise-induced chest pain. Temperature is slightly high, right? Blood pressure is slightly high for this age, right? Mild neck stiffness is going on, right? So we can't explain everything with myocardial ischemia. This child might have some other infection going on, possible. However, they are at the moment worried about not about those, but the reason for chest pain. Reason for chest pain. Now, could this be asthma? Simply no, because asthma doesn't cause ST elevations. Costochondritis, we have already explained, discussed, that doesn't cause ECG changes. Myocardial ischemia, yes, right? Myocardial ischemia is very likely out of these 5 answers, because that will explain most of the things. Pneumothorax does not cause ST elevation. And then precordial catch syndrome, we have already discussed, it's fairly benign. That doesn't cause any systemic manifestations or ECG changes. Right, now with this question, now if you look at this, right, I'm sure you may have done some postgraduate exams also in pediatrics, right? Compared to those questions, this question looks easier, right? This question looks easier. Also, most of the history and examination finding might not be very important for decision making here, because ST elevation is given. So you know that it is something to do with cardiac. And the answers are very simple because it has only one cardiac differential diagnosis. So there can't be any ambiguity. They don't say anything like pericarditis. Now we might have to struggle a little. Could this be pericarditis and myocardial ischemia? Right? Or They don't say whether it is inferior MI, lateral MI, anterior MI, posterior MI. No, that kind of uh, deep knowledge testing is not happening in this question, right? So what is tested here? Whether we understood that this is something to do cardiac, right? And they also wanted us to know whether we understood these ECG changes are compatible with myocardial ischemia, right? So this myocardial ischemia, we don't know why it is happening, right? Because he has some fever. This could be some myocarditis going on. We don't know, and that we don't have to know that either. Right? Important thing is it's very important to come to a diagnosis very fast, quickly, because when you go to further questions down, we will understand there are some questions where you have to read the full page. Right? Remember, this is not about testing knowledge only, but testing how quick we are coming to decisions. That is why we have only 2.5 minutes per question. Right. Next question. A child with non-congenital heart disease presented with this lesion. What is the underlying diagnosis? What is the underlying diagnosis? Right. They don't ask what this lesion is, but they ask what the underlying diagnosis is. Right. Okay. What do we think as the lesion? If somebody asks the lesion, what are these? Yeah. You see on the toe, you see some discoloration, right? Discolored area. So these are known as Janeway lesions, right? These are Janeway lesions. You see Janeway lesions in infective endocarditis, right? Infective endocarditis. So Janeway lesions could occur in fingers or toes. This is the classic appearance of Janeway lesions. Therefore, we need to know the diagnosis as infective endocarditis, right? You see, when you read the answers, deep vein thrombosis, factor 5 leading this deficiency, this can cause thrombosis, idiopathic thrombocytopenia purpura, right? This causes low platelets, and that leads to bruises, right? Skin bruises, right? Meningococcal septicemia, you get a generalized purple color non-blanching rash, generalized purple color non-blanching rash, and child will be very ill looking. Subacute bacterial endocarditis, again we see out of five answers, this is the only heart related option. This is the only heart related option. The question starts by telling a child with known congenital heart disease. So this is a child with congenital heart disease, and the examiner is asking what the likely diagnosis is for him to have this lesion, right? So a bit of knowledge and putting things together is what is expected here, right? So the answer is subacute bacterial endocarditis, right? Deep vein thrombosis, deep vein thrombosis, they will present with edema, leg edema. There could be associated calf tenderness. So that is the type of scenario that they will present. And factor 5 laden disease, this can cause thrombosis in children. There are some other causes of thrombosis in children like protein S deficiency, protein C deficiency. They all can cause. And then factor 5 is another condition. They can present with thrombosis, cerebrovascular accidents, hemiplegia, right? Then idiopathic thrombocytopenic purpura, if you later we will, in one of the other sessions when we do hematology as a separate part, we might do how they appear. So there are bruises, purpura, right? Meningococcal septicemia is completely different, right? Okay, right. Now, this question number 4. 3-year-old girl was admitted with poor feeding, recurrent apneas, and poor peripheral pulse. She required resuscitation and ventilatory support. Arterial blood gas shows severe metabolic acidosis. He responded well to prostaglandin. Saturation increased from 84 to 95. Please try. Right. Okay. So this is a 3-year-old girl admitted, 3 days old girl, poor feeding, recurrent apneas, poor peripheral pulse. Right. So it's important to know peripheral pulses are poor. Right. She required resuscitation and ventilatory support. Arterial blood gas shows metabolic acidosis. This means that the peripheral perfusion is not good. So is hypoxic. So lactate is produced due to anaerobic oxidation. Prostaglandin infusion caused saturation to increase from 84% to 95%. Right. Okay. So what is the likely diagnosis? Right. Now here, how are we going to approach to this question? How are you going to approach to this question? Now, a few things that we need to know here is prostaglandin, right? Prostaglandin helps the babies if it was a duct-dependent circulation, right? Duct-dependent problems. Children might get better when they get prostaglandin. Why? You know this ductus arteriosus, which connects pulmonary artery to aorta. Pulmonary artery to aorta usually closes towards 3 days of life. That is why she started to deteriorate on day 3. Day 3 deterioration in a baby, always think, could that be closure of the PDA? That PDA probably is closing now, right? When PDA closes, when you give prostaglandin, it reopens. It reopens, right? So that is why prostaglandin therapy has been beneficial for this baby. So if we understood that amount, that much, you know that this is a duct-dependent circulation, right? It's a duct-dependent circulation. Having the duct as open has been critical for this baby's survival, right? Now we need to know what kind of duct-dependent problem this is, right? So then it can't be urea cycle disorder. Urea cycle disorders will not improve with prostaglandin, right? And then sepsis, again, will not improve with prostaglandin. What are the possibilities then? It could be interrupted aortic arch, transposition of great arteries, then tricuspid atresia. In transposition of great arteries, what happens? Aorta starts from the right side of the heart, isn't it? Aorta should start from the left side, but here it starts from the right side, right? Here it starts from the right side, right? So that's the difference, and pulmonary starts from the left side. Now here it says the peripheral perfusion has been poor. What does that mean? peripheral circulation, say lower limb perfusion was poor. You see, peripheral pulses are poor, right? So peripheral pulses are poor. When you give prostaglandin, possibly peripheral pulses improved. That is why saturation increased, right? So when that is the case, we need to think, would that be something to do with aorta? Something to do with aorta. One of the possibilities, say, if you have coarctation of aorta, what happens? Descending aorta will not get enough circulation. Descending aorta is not going to get blood because of coarctation. Then when you open the ductus, what will happen? Descending aorta will get blood from the ductus. Then you will get better perfusion and saturations, everything might get better. So if you had coarctation of aorta as an answer, we could have thought that it is one possibility. It might not match the best because coarctation of aorta will not cause this low saturations generally. However, something to do with aorta might match as the answer. Right. If I am to show another picture, this one. Right. So there is a clear picture here. Right. I hope you can see this one. So interrupted aortic arch. So what happens is there is a disconnection between ascending aorta and descending aorta. Right? Ascending aorta and descending aorta is disconnected. However, thanks to PDA, descending aorta will get some amount of fair amount of blood. But by day 3 also, what happens? This PDA will close, and there won't be enough blood to the lower limbs. This is what happens in interrupted aortic arch. Soon when you give prostaglandin, the ductus will open, and then through the PDA, you will send enough amount of blood again. Then the child's saturations, the lower limb perfusion, pulse volume will get better. Right? So this is the amount of knowledge that they have tested in this question. So we need to know to select the answer as interrupted aortic arch. Right? Interrupted aortic arch is the answer. Right? Transposition of great arteries usually does not cause poor peripheral circulation. Right? It can cause cyanosis, but it doesn't cause poor peripheral circulation as such. Tricuspid atresia, what happens is tricuspid valve is not formed properly. There do you have tricuspid valve in the right side of the heart. Therefore, blood from right atrium will not come to right ventricle. Right atrium to right ventricle. That circulation is affected, not the systemic circulation greatly. It's the pulmonary circulation, right? So that's not the answer. So the best answer should be interrupted aortic arch, right? So this is not something that is commonly tested. Therefore, it's important to know this concept. So these questions could be repeated. Right. I will not discuss X-ray related questions. Some of these X-rays are not very clear when you put that into PDF. Right. This question. 13 years old child presented with a 3 month history of chest pain on exertion. He is a keen football player and has had to miss a couple of games, particularly during cold weather, because of this problem. So, chest pain while exertion. The pain is described as tight feeling over the lower chest, which is difficult to localize. Pain is associated with breathlessness. His symptoms gradually resolve after resting. Examination is entirely normal. So what do we think as the diagnosis here? Yes. Now here, it's again 3 months history of chest pain on exertion. Chest pain on exertion. So we need to think about a cardiac problem or respiratory problem. That is when you get chest pain while exertion, right? And he has missed a couple of games, particularly during cold weather or winter months. So probably the condition is getting more severe during winter months, cold weather. And there is tightening pain. It is difficult to localize, which means it is likely to be a generalized pain, right? Generalized pain associated with breathlessness, right? So what could be this one, this type? So it can't be precordial cat syndrome because that can't have a seasonal variation, right? And that usually doesn't exacerbate with exercise. Pneumothorax, again, unlikely for a pneumothorax to persist for 3 months. Plus, if it was pneumothorax, we expect child to have abnormal features on examination. Myocardial ischemia should not have a seasonal variation. If it was myocardial ischemia, we expect child to have a fairly localized pain. Costochondritis will cause a tenderness, which is not described here. So the best answer here should be asthma. Right. Best answer should be asthma. Right. Right. Next question. You see the length of the question. Right? It goes on from page number 6 to page number 7. This is where the time management matters. Right. Okay. A 13 years old girl with non-sickle cell disease was admitted with fever, cough, and malaise. She has been admitted on several previous occasions for sickle cell crisis with colicky right upper quadrant abdominal pain. She is the only child of Nigerian parents born in the UK, living in London. Her father is an accountant, mother is a housewife, and they live in a small modern flat. She has just returned from a holiday in Nigeria. On examination, she was anxious, moderately distressed. She was pale and slightly jaundiced. Her temperature was 37.8. Right? 37.8. Slightly febrile, very slightly, right? So 37.5 is the cutoff. Pulse rate is slightly high. Respiratory rate is okay. Dull percussion over right upper chest anteriorly with bronchial breathing. Dull percussion and bronchial breathing, we know that it is pneumonia. It has only localized to a particular area, so it is likely to be a lobar pneumonia in that method. The liver edge was 2 centimeters below palpable. Spleen was not palpable, and there is slight tenderness on right hypochondrium. Slight tenderness on right hypochondrium. We know that she also had right upper quadrant colicky abdominal pain as well. She has the both. Specimen of urine contains excess urobilinogen. So there is some hemolysis or jaundice going on. Right? Excess urobilinogen is there. And then no proteinuria, right? No glucose, nothing, right? Okay, so investigations, hemoglobin 6.2, which is really low, right? So this child is obviously anemic. WBC count is slightly high. Plasma bilirubin, I would say slightly, it's high. And then sodium is normal, right? Sodium is normal. Urea is 7.6, fine. And X-ray shows opacification of right upper zone. Right upper zone opacification is there. Right. Oxygen saturation is 96%. What is the most likely cause for her febrile illness? What is the most likely cause for her febrile illness? Right. Okay. Now, before we go to question, right? Before we go to answer this question, now do you see this question, the length of this question, this long? We need to read word by word. Whereas this question, short, right? This question, short. This question, short. This question, short. I personally, right? If I were the candidate and when I did MRCPCH, I skipped these long questions during my first round, right? During my first round, when I see that the question is 1 page long, 2 pages long, I simply skip that, go to questions with shorter or less amount of details. That will save my time. And then once I'm happy that, okay, I have finished 50 questions out of 60, I have half an hour more to go. Okay, now I'm not going to fail. Now I'm going to go and read these long questions. Right? That way worked well for me. I hope it will be the same for you as well. So if the questions are very long, right, I suggest to skip that during first round, right? Okay, so this is something that I would have skipped during first round, right? Okay, now what is asked, right? What is the most likely cause of his current febrile illness? Now, what is the current problem here? It's the child has got a localized lung signs with opacification of the right upper zone, which means this child is likely to be having a lobar pneumonia, right? That is what is tested, right? That is what is tested. Now, you see they are from Nigeria, all these living in a flat, right? That might not be very relevant, right? That might not be very important, but the problem is what? We need to read those, and that will take a lot of time, right? So we need to make sure the other questions, when we know that the questions are easy and straightforward, do them and save time for this kind of lengthy questions. Right. Okay. So what is the likely cause for febrile illness? Staphylococcus pneumoniae, Mycoplasma pneumoniae, pneumococcal pneumoniae, pneumocystis carinii, and sickle cell crisis. Right. Any comments? Right. Okay. Now here, we need to know that it is unlikely to be sickle cell crisis. Now, sickle cell crisis could be ongoing. That's a different thing. But that is not the reason for current febrile illness. Sickle cell crisis per se will not cause fever, right? So that is unlikely. And then sickle cell crisis per se, it can cause chest syndrome, right? Sickle chest syndrome can cause infarctions. But here it clearly says, right? It clearly says that dullness on percussion with bronchial breathing. So this is classic with consolidation or pneumonia. right? So examiner is testing whether we understood that the child is suffering from lobar pneumonia. When we understood that it is lobar pneumonia, he is now testing bit of microbiology knowledge in us. What is the commonest organism causing lobar pneumonia is the next question. That is Streptococcus pneumoniae or pneumococcal pneumonia, right? Pneumococcal pneumonia. So this is what causes this kind of pneumonia. Staphylococcus pneumoniae will cause pneumatocyl formation, right? And they will present with very high fever with chills and dry cough. Mycoplasma usually causes bilateral pneumonia or bronchopneumonia. There will be bilateral shadows with prominent pilar involvement, which is not given here. Pneumocystis carinii will cause very nasty pneumonia that usually occurs in children who are immunocompromised, like HIV, you know that. And if that is the case, we expect changes to be there, clinical signs to be there in both the lungs, not only one lung, right? Sickle cell crisis, of course, is out, right? So the answer should be pneumococcal pneumonia, right? I'm going to skip these 2-3 questions because they all have X-rays. Right? Neurology and development. Right. So we have discussed few questions related to respiratory, few questions related to CVS. Now we are moving down to neurology. Right. Neurology. Okay. A 2-year-old child became coryzal. He vomits 3 times and subsequently becomes drowsy, followed by a generalized tonic-clonic seizure. Blood glucose 4.6, which is normal, sodium 135, potassium 4.5, creatinine 30, urea 2.5. Right. Okay. So to make the things easier, I would say urea, creatinine, sodium, potassium, sugar, they are all normal. Right. They are all normal. Right. So if that is the case, what do you think as the diagnosis here? Is it aspirin toxicity, cerebral edema, diabetic ketoacidosis, febrile conversion, or glycogen storage disease? Glycogen storage disease. Right. Okay. So what do we think as this? Now, if it was aspirin toxicity, right, which is unlikely because nowadays we don't give aspirin to children with fever in the UK unless there is a clear indication such as Kawasaki, right? For all febrile illnesses with coryza, we don't give aspirin, so we don't. That's unlikely. Plus, aspirin toxicity will have some other features like they will have tachycardia, tachypnea, increased sweating. Older children can also have tinnitus, right? Older children also will have tinnitus. So this child is not having any of those, right? So that's unlikely. Cerebral edema. Cerebral edema. He vomited 3 times, subsequently becomes drowsy, followed by a generalized tonic-clonic seizure. Right. And in the background, it says, child was coryzal. So he has had cough and cold as well. So could that be cerebral edema? Right? Possible. It can cause seizures. Right. So we can take it as a possible answer. Diabetic ketoacidosis is out because in diabetic ketoacidosis, you expect blood sugar to be very high, right? Here, the blood sugar is normal. Diabetic ketoacidosis, the cutoff blood sugar is 200 milligrams per deciliter or above 11 millimoles per liter. Here it is 4, so it can't be diabetic ketoacidosis. Right? Could that be a febrile conversion? Yes, febrile conversion is Possible. And then could that be glycogen storage disease? Is that possible? Glycogen storage disease can cause seizures. If that happens, that is generally due to hypoglycemia. Here, the blood sugars are normal, right? 4.6 blood sugar is normal. So that should not cause seizures, right? Then the likely two answers are either it is febrile convulsion or cerebral edema. But given the history of child who was coryzal, right, couple of days ago, and now having seizures, and then they ask, what is the most likely diagnosis, right? If you are working in one of the UK hospitals, when this child comes, when you are the registrar, are you going to jump and do a CT scan is the question that is tested here. No, because why? Very likely this is a febrile conversion. You might observe. But if the examiner said that child's blood pressure is high, pulse rate is low, the examination revealed papilledema, then you need to think, could this be cerebral edema or increased intracranial pressure? But that information is not there here. So common things are common. We need to go by commonality. So the most likely diagnosis is a febrile convulsion. Right? Febrile. Right. A nine months old infant was cynosed at birth and had a cardiac operation at 3 months of age. What condition is shown here? What condition is shown here? What do we see? We see that the left eye looks slightly smaller than right. So this is what we see here. This is what we see here. Right. Then what could be the likely diagnosis? What could be the likely diagnosis? So this is the typical appearance of left-sided partial ptosis. Right? Left-sided partial ptosis. When do you get partial ptosis? Due to third nerve palsy, ipsilateral third nerve palsy, right? So this, in this case, it should be left-sided. And in third nerve palsy, you get other features. What are those? There will be partial ptosis, meiosis, and anhydrosis, right? Anhydrosis, absent sweating, right? Meiosis is constriction of pupils. I don't know whether you can see that this child's pupil, right? So you see left-sided pupil is slightly smaller than right side. So there is meiosis, and then there is this partial ptosis, and hydrosis is not something that we can see in this picture, right? So what is the likely diagnosis? Is it left-sided Horner syndrome? Is it left-sided lower motor type facial nerve palsy? Is it left-sided ptosis? Is it left-sided upper motor neuron type facial nerve palsy? Or is it right-sided Horner syndrome? Right. Right. Okay. Now here again, right-sided ones we can easily remove because this is something to do with left side. Right. So right-sided is out. Right-sided is out. So that is not the answer. And then could this be facial nerve? Facial nerve. You know, facial nerve, whether it is upper motor or lower motor, lower motor, the characteristic feature of facial nerve palsy is there will be deviation of mouth to a side, which you don't see in this child. Mouth is exactly symmetrical. That can't be the answer. Then whether it is left-sided Horner syndrome or left-sided ptosis is the question, right? So Horner syndrome, to diagnose Horner syndrome, we need to have some other like extra features, right? So they can have ptosis, right? They can have ptosis. And then we also have to demonstrate that they have small pupils and reduced sweating and hydrosis. You don't see them on this picture, right? And Horner syndrome is commonly secondary to thoracic or cervical primary tumors, or it could also be due to damage to cervical chain, which could be possible because this child has undergone a cardiac operation. That is the relevance of this cardiac operation to this question, right? So if you put everything together, right, we can definitely say that there is left-sided ptosis, right? Left-sided ptosis we can say, but whether it is Horner or not, we can't just say by looking at this picture, right? Therefore, most likely diagnosis here should be left-sided ptosis. So when we do MRCPCH courses, right? So we do them as like topic wise. So when we do neurological cases, we do a lot of uh, ptosis and all those cranial nerve involvement cases. And then we have separate sessions on picture tests. There we will do pictures, right? So when we do them, a lot of time for exam, before exam. Soon when you see the picture, you know, okay, this is this. But today we might not be that familiar to this exam setting and the type of questions, and you might feel that these are comparatively hard or less clear. That is because we have not gone through these questions a lot, because this is your first session. But when you go through this, you will understand that these are not difficult. Next question. A 12-year-old boy with learning disability was seen in Child Development Center with 12 months history of increasingly awkward gait, difficulty in getting footwear. For the examination, he has got scoliosis, marked pes cavus, absent lower limb reflexes, and extensor plantar response. So 12 years, coming with awkward gait, we would say ataxia, right? So there is a gait problem, right? Difficulty in getting footwear. So this might say something about the foot, right? There may be some abnormalities happening in the foot, right? So we need to get that clue clearly. And scoliotic pes cavus, so there is abnormality in foot arches, right? And lower limb reflexes are absent with extensor plantar response. Now, this question, rather than excluding other possibilities, you can straight away come to the diagnosis, right? When you say pes cavus, absent lower limb reflexes, and positive extensor plantar response, right? So then, what is the likely diagnosis? That should be what? Any comments? Anyone? Yeah. So this is Friedreich's ataxia, right? Friedreich's ataxia. So what happens in Friedreich's ataxia? It's a progressive neurological disorder, right? It's a progressive neurological disorder and autosomal recessive. Autosomal recessive, right? They can present during latter part of their school age, right? They present with ataxia. They also can have dysarthria, abnormalities in foot arches. Particularly, they can have this pes cavus. Pes cavus. Right. So dermatomyositis. So answer is that. Answer is that. So why not other answers are correct is the question. Dermatomyositis. You know dermatomyositis, as name says, there is an inflammation in dermato, that's the skin, and myo is muscles, right? So dermatomyositis is that, right? So when you have dermatomyositis, there will be an inflammation in the skin, right? Skin inflammation will cause what? Some rashes. You may have heard something called heliotropic rash, right? Heliotropic rash. Gottron's papules, right? Gottron's papules. So those are the type of rashes or skin manifestations you get in dermatomyositis, right? And then, please give me a second. Right? So dermatomyositis, there will be skin manifestations like what? Gottron's papules. There will be rough skin, inflamed skin on the knuckles. Then you have what? Heliotropic rash, purple color rash on the eyelid. So those are the dermatological manifestations. And then you get what? Muscle manifestations like proximal myopathy. So they might present with positive Gowers sign, proximal muscle weakness, waddling gait. This child doesn't have any of those. Then Duchenne muscular dystrophy, right? Duchenne muscular dystrophy. Again, the presentation is similar to myopathies, waddling gait, positive Gowers sign, right? Calf hypertrophy. It's very unlikely for a Duchenne child to present at 12 years because they present at around 3 to 5 years of age. Right? Then hereditary motor sensory neuropathy will not cause all these manifestations explained in this question. So that is unlikely. Then spinal cord tumor, right? Spinal cord tumor can cause some of these manifestations. However, if it was a plain and simple spinal cord tumor, we usually expect lower limb reflexes to be exaggerated. Right? And spinal cord tumors generally doesn't cause pes cavus. It could happen, but extremely rare. Right? So the most likely answer is Friedreich's ataxia. Right. Next question. Now this is simple. Right? See, this 10-year-old child, sorry, so this is the growth chart of a 10-month-old boy who was admitted to hospital because of vomiting and poor weight gain. The baby fed well on a mixed diet. The stools were normal. There were no abnormal findings apart from wasting. Right. Now what has happened? This has been the growth chart. This has been the growth chart. And the baby was admitted to hospital at this point. After admission, the growth is improving. Right, growth is improving. What have we done after admission? Right, hospitalized because of vomiting and poor weight gain. Baby fed well on mixed diet. So this probably is after admission. Baby fed well on a mixed diet. The stools were normal. There were no abnormal findings apart from waste. Now after admission, what is happening is nicely gaining the weight. Right. Okay. So what do we think as the most likely diagnosis? Could that be celiac, house milk protein allergy, cystic fibrosis, gastroesophageal reflux disease, inadequate calorie intake? Yeah. Any comment? Right. Okay, now here again, what we have to know is to exclude other possibilities and come up with a most likely diagnosis, right? So we'll see what the likely diagnosis is. So celiac disease, right? If it was celiac disease, we expect child to be on gluten-free diet to improve his weight. Here it says child has been on mixed feed. So that could be anything, mixed diet, right? While on mixed diet, children with gluten sensitive enteropathy or celiac disease will not improve, right? So that is unlikely. House milk protein intolerance, in that case, child should be on house milk free diet, right? Or extensive hydrolyzed formula, right? This baby has not been on any of those diets, still has started to gain weight, then that is unlikely. Cystic fibrosis, right? So cystic fibrosis again, here it says vomiting and poor weight gain. Stools were normal. Now it is unlikely, right? Stools were normal. We know in cystic fibrosis, they get steatorrhea, bulky stools. Here, the stools were normal. Then it is unlikely to be cystic fibrosis. And cystic fibrosis children will not improve just because they were admitted and given on mixed feed, right? So that is unlikely. Right? And then could that be gastroesophageal reflux disease? Again, this child has vomiting. That could be a presentation of gastroesophageal reflux disease. However, we have not done a single modification. We have not even made child to eat thick food. Anti-reflux medication were not started. Then it is likely to be what? That is unlikely. So then the likely diagnosis is what? Inadequate calorie intake, right? Inadequate calorie intake. Now I'm explaining these questions around the questions. We are having a big discussion. This is because when we get different kinds of scenarios, we know how to approach. It is very unlikely that we get this same question. There are occasions where we get same question. But even if you don't get the same question, we now know how a celiac disease would manifest. They will present with buttock wasting, distended abdomen. Will get better with gluten-free diet. House milk protein intolerance, they will get better if the child was started on a special formula. They usually have blood in stools. Blood in stools here, stools were normal. Cystic fibrosis, there will be a history of recurrent chest infections. And there will be bulky stools. It's difficult to flush. Gastroesophageal reflux, they will say that the child had recurrent episodes of regurgitations, vomiting, arcing back of the head, right? So that information is not given, right? None of those will just improve by admitting, but we need to start specific diet or a treatment. This child has just improved. So what probably might we have done? Improving the calorie. Now, when it comes to calorie, it doesn't mean that this child was not given with calorie or this child was poor, right? In countries like UK, not eating due to poverty is unlikely, right? It is not about poverty. There may be issues with child care. There may be an element of negligence. There is no one to look after. They probably are single parents. This mother might have several other children. And we used to see some mothers come with 8 children. The eldest is 19 years, youngest is 10 months. That whole range. And then they are born to different fathers, right? That's okay. Yeah, right. And then there is no responsible father, right? And there no extended family support like what is seen in Asia and Africa. We don't see that in United Kingdom, right? So that is why social services are highly involved, because if there is no social services, the child might end up with nobody, no one, right? So we need to find out why this child is not getting enough calorie. Is it just poverty, or isn't there anyone to um, look after this child? Those are the few things that we need to know, right? Now, in the light of this growth chart, select the most helpful next action. Next action. We know the diagnosis now. Now the question is, now what is the most important next action plan? Is that a discharge planning meeting, food diary for 1 week, measure measure IgA anti-transglutaminase antibodies, esophageal pH monitoring, RAST test for cow's milk protein allergy. Right. Now here, it's pretty obvious. No point of checking cow's milk protein allergy because we know that it is not cow's milk. Right? No blood in poo, nothing. Esophageal pH monitoring could have been the ideal investigation if you were seriously suspecting that it is gastroesophageal reflux disease. Right? Measurement of IgA transglutaminase antibody could have been the answer if you were thinking about celiac disease. Right. Now, what should you choose? Is that food diary for 1 week or discharge planning meeting? Now the child has got better with the diet, the mixed diet that the hospital has provided. Right. So there we haven't done a lot on diet. Now the child is going to go home. When the child is sent home, he will start to live in the same social circumstances. Then what will happen? He might fail to grow again. Right? Now, as pediatricians, it's our responsibility to think about what is best for this child when he is discharged. Therefore, for these children, right? So most of the UK pediatrics units will have a social worker, a dietitian, right? And then there will be a discharge planning meeting. We don't just discharge, okay, this is your diagnosis card and this is you go. No, we don't do that. We are not supposed to do that legally, right? We need to arrange a discharge planning meeting with multidisciplinary people, like what we do for child abuse. This could be taken partly as a neglect, if that is the case, right? We need to make a good discharge planning meeting and then decide what to do, right? Yeah, if they say now, no, it doesn't look like anything to do with social, we need to have more monitoring, right? Many days of some more days of monitoring with diet plan or food diary. You can do that, but next thing to do is discharge planning. I know that to answer this question, knowing theory might not be enough, right? We need to know how things are managed in the UK, not other countries, UK. So that part is tested, right? So there are particular guidelines as to how to manage children with malnutrition, right? There is a particular section where you think malnutrition is probably due to poor social support or possible neglect. There, it clearly mentions discharge planning meeting is needed. So this question tests whether we knew that piece of knowledge. Right. Okay, so that's it. Now I'm discussing these questions not just by reading guidelines or reading standard textbooks. Of course, I do that, but more than that, I again think, okay, in the ward that I worked or previously worked and work, how did we do? So that clinical experience is needed. to decide, especially AKP and the clinical MRCPCH clinicals. They exactly test how things are happening in the UK. That is the importance of having some sort of preparation for this exam, because it is not just testing the knowledge. They would test how things happen in the UK as well, right? Next question. A 4 weeks old baby presented to outpatient department with a history of sudden jerky movements noticed by his mother almost from birth. They are seen most prominently while sleeping. His mother thinks that they are more obvious recently and may number from 1 to 2 to about 10 or more in a few hours of sleep. Each jerk seems to last for about few seconds and appear to involve an isolated limb. Physical examination is normal. Which of following is the most likely diagnosis? Right. Okay. It's a good idea to highlight things. This is a short question, right? History of sudden jerky movements. Right? That is something that we need to know. And predominantly during sleep. Predominantly during sleep is something that we need to know. And each jerk lasts for about few seconds, right? Few seconds, and limbs are involved. Physical examination is otherwise normal. Physical examination is otherwise normal. Right. What do we think as the diagnosis? Is it benign sleep myoclonus, drug withdrawal syndrome, hypocalcemia, infantile spasms, myoclonic epilepsy? Right. Now, what are the obvious things that we can exclude? Now, if it was hypocalcemia, until you correct hypocalcemia, the seizures are not going to get better. So here there is no treatment given. They settle by its own, right? Drug withdrawal syndrome. So there, who is going to take drugs? It's the mother. Say mother took drugs, right? Say heroin, say some other drug like cocaine, you name. When you start to work in the UK, you will see mothers will come with all sort of drug addiction, right? So they present, and then what happens? Children, babies will have withdrawal symptoms. Usually these withdrawal symptoms stop by around like first 1 week after birth. Now this is a 4-week-old baby, and the things are getting worse now. If it was drug withdrawal, we expect things to be worse at birth and gradually get better with time. So here it's the other way around, unlikely, right? And if it was drug withdrawal, there will be jitteriness. Usually that jitteriness is bilateral. Infantile spasms, right? Infantile spasms are unlikely to occur only in one isolated limb, right? It is unlikely isolated limb. You know, there will be sudden flexion of both upper limbs with associated neck flexion, what we describe as salam attacks. Right? Here the description is not compatible with salam attacks, number one. Number two, infantile spasms occur at any time. Here, this is only occurring in sleep, right? So that is unlikely. And also, if you think about baby's age, infantile spasms usually starts to present around 3 to 4 months of age onwards. This baby to have infantile spasms, I would say this boy is too young to have it yet. Then could that be myoclonic epilepsy? Again, myoclonic epilepsy is possible, but myoclonic epilepsy does not necessarily have to occur only during sleep, right? So this baby is otherwise well, physical examination is normal, and few jerks occurring, right, lasting for few seconds, only during sleep. So what is tested here? Whether we know that this is benign sleep myoclonus. So the answer is benign sleep myoclonus. Right. Treatment is reassurance. Right? We don't have to do anything. Reassurance is enough for benign sleep myoclonus. Right. Next question. Right. A previously well 16 years old boy presented to outpatient clinic with 6 months history of frequent headaches. Recent problem with balance and had occurred while playing football for his school team. The headache was relieved by lying flat. Now that is very important piece of information. Headache was relieved by lying flat. There was a strong family history of migraine. Physical examination was normal apart from positive Romberg sign and unsteady gait on heel toe walking. Reflexes were normal. Reflexes were normal. Right. What could this be? All right. Again, we need to exclude few possibilities because it's very difficult to find out the correct answer. If you struggle among 5 options, we need to make sure that we remove at least 3 options confidently. Then we need to argue whether it is this or that, right? If we are having 5, that would be difficult. Now, spinal cord tumor. Now, spinal cord tumor should not cause headache. Spinal cord is spinal cord. That generally doesn't present with headache. They might present with other features like increased reflexes, difficulty in gait, you name, they are all possible, but it generally doesn't cause headache. Migraine. Migraine, migraine is unlikely to cause neurological manifest, like it can cause, but this positive Romberg sign, right? An inability to walk on tiptoe, right? Those are like classic neurological features. Here we need to think of like organic neurological problem than non-organic causes like migraine. So this is unlikely, right? This is unlikely. And then what? Could that be late onset muscular dystrophy, such as Becker's? Now that is grossly out. Right? Becker's will have what? Pseudo hypertrophy of cows, positive Gauer sign, right? Not Romberg sign. They will have Gauer sign, and Becker's generally doesn't cause headache, right? So that is also out, right? Then what is the possibility? Is it idiopathic or benign intracranial hypertension, or is that Arnold-Chiari malformation? Arnold-Chiari malformation, that's a defect in neural tube formation. So there could be associated hydrocephalus, CSF leak. All these are possible, right? So when you have CSF leak, there would be low CSF in the around the brain that can cause low CSF pressure headache, right? That will be more so when the child is standing. When the child is standing up, that can cause more CSF loss. So the headache might get worse. Here it says headache was relieved by lying flat. When you lie flat, right? When you lie flat, the CSF leak will be less, and there will be good cushion around the brain in that case. So the headache will get less severe. Also, when you have Arnold-Chiari malformation, there could be associated hydrocephalus and associated posterior fossa space occupying clinical signs, right? So then they can have all those abnormalities like this difficulty in walking, right? Inability to perform heel toe walk, right? So we need to think about structural brain problem here rather than a non-organic pathology. And then when you say headache was relieved by lying flat, then we need to think about CSF leak, that kind of scenarios. So the best answer should be Arnold-Chiari malformation. Right, Arnold-Chiari malformation. Right. Okay. Right, now we have done a fair number of questions, and while we were doing questions, we also discussed other possibilities. That is why it took so long to discuss some questions. Right, now, when you are seriously preparing for MRCPCH, if that is the case, if your taste week, if your taste week is over, or taste time is over, if you have seriously decided, okay, now I'm going to do this exam, right? We need to think it very seriously, right? Because why? Passing this exam is rewarding, isn't it? Say, when you pass theory components and then medicals, then you will get GMC registration straight away, right? GMC registration straight away. And then you will get a middle grade job rather than a junior doctor job. If you do PLAB, usually you end up in getting a junior clinical fellow job or a SHO job, FY1 or FY2 job. But if you have MRCPCH, you will get a better job, better position. Now for that, we need to work hard, right? We need to work hard. Generally, we need at least good 6 months of dedicated work, dedicated preparation to prepare for this exam. Otherwise, it's difficult. If you check random questions, you will feel, okay, this is easy. It's good if you feel that questions are easy, but what is the problem with these questions? It is not like doing randomly 5 questions. When you do a full paper, this time factor matters a lot. We need to see whether I can come to the correct answer within 2 minutes. That is one. Number 2, how many such correct answers do I get out of 60? If it is AKP, 60. Right? No point of getting 40 correct, right? Because the pass mark is not 50. Right? Pass mark is around 70. So we need to target for 70. So we need to make sure that the number of mistakes that we do is minimal. That is where training and preparation matters. Anyone can do the exam. Anyone can get 50 marks. Not anyone, many of us with existing knowledge. But the challenge is getting that other 20 marks, right? Other 20 marks is the challenge, right? RCPCH very well knows that 20 marks is the challenge. That is why they made the pass mark to be high to make this exam competitive. So they will only give the jobs and GMC registration for the suitable people, right? So that we need to understand. Randomly doing 5 questions are not going to be very helpful. You can do that during like light preparation, but when we are serious, we need to do them at a stretch and see how many answers I got, right? What areas are deficient in me, right? So how am I going to improve my skimming ability? How is my ability of highlighting important information? Now these RCPCH examiners purposefully will give extra information for you to make sure that you struggle with time, right? Struggle with time. Even that is another way of filtering who the best people are, right? So we need to make sure that we avoid that barrier. So we know how to manage our time. We know how to take decisions very fast. We know how decisions are made as per UK guidelines as well, right? And we also have to make sure that those decisions are mostly correct. Therefore, I achieve 70 marks. That is the challenge. So to overcome that, overcome all those barriers and to achieve that goal successfully, we need to make sure that we have at least good minimum of 6 months preparation, right? If you don't prepare, if you think, okay, they just a random exam and I'm going to just go and do, then two problems. There's a higher chance to fail. Number two, it's a lot of money. It's a lot of money, so we should not do that. It's like any other, like it's like final MBBS exams. When we had final MBBS exam, we were very serious during last 6 months or so. That was our life. That is what we did. So we need to do that commitment for this. So the good thing is, not like PLAB, this is just only pediatrics. When you do a couple of papers, we understand the art of it. Anyone can pass with due amount of commitment. So this is not an exam which is difficult, right? Simple things will be tested, but they will check if those simple decisions are mostly correct. There are enough and more students who got 60 and failed. 60 failed. Then you need to attempt again, right? So that is where the challenge is. We have to understand that challenge and work on that, right? Okay, we'll do a couple of more questions and then we will stop the session for today, right? 13 years old girl with non-sickle cell disease was admitted with fever, cough, and malaise. It's the same question, right? I'm not going to repeat, but here the what is asked is different. What is the most likely cause for her upper abdominal pain? You know, it's the same Nigerian girl with sickle cell anemia, presenting with difficulty in breathing. She has this opacity. On top of that, you can remember, she presented with upper quadrant abdominal pain, colicky upper quadrant abdominal pain, right? And there was 2 centimeter hepatomegaly as well. She was slightly febrile. In our previous question, the examiner was worried to know what her respiratory problem is. Now they are asking what is the reason for her upper abdominal pain. Upper abdominal pain. Yes. Yes. Now that should be easy. Yes. Now this is a hemolytic disease. You know, hemolytic diseases, they will produce a lot of bilirubin and then they can have pigment stones. Right. So these are good candidates or common candidates to get biliary stones. Right. Biliary stones. So if it's a biliary stone, they can present with biliary colic. Right. Sickle cell crisis per se will not cause upper abdominal pain of this kind. Renal colic will cause loin to groin pain, not upper abdominal pain. Hepatitis B infection is likely, and that does not cause this kind of colicky abdominal pain. Chronic pancreatitis will cause a central abdominal pain radiating through to the back. And chronic pancreatitis and sickle cell anemia are not classically or typically linked, but biliary colic is classic in them. Not only in them, any chronic hemolytic anemia can cause gallstone formation, so they might present with biliary colic. So what is tested here is, as a registrar working in a pediatric busy ward in day assessment unit, if you get a sickle cell anemia child with colicky abdominal pain, which is located to the upper quadrant, does biliary colic come as the first possibility into our mind? That is simply what is tested, right? So that's it. And then what is the next most useful investigation in establishing the cause of this upper abdominal pain, right? So you know the diagnosis is likely a biliary colic. For you to get a biliary colic, there should be a gallstone. What is asked? What investigation are you going to order now? What investigation are you going to order now? Is it CT scan abdomen, abdominal ultrasound, HIDA scan, hepatitis serology, or plain X-ray abdomen? You see, everyone has an answer. So if you thought that it is renal colic, you would have chosen plain X-ray abdomen as the answer. If you have chosen hepatitis B as the answer here, you would have chosen hepatitis serology here. Right? If you thought chronic pancreatitis, you might go for CT abdomen rather than ultrasound scan abdomen. HIDA, of course, is not relevant here mostly. So the most likely diagnosis is biliary colic. So what is asked? Next most useful investigation, right? Of course, if you do a CT, that will show the biliary stone very clearly. But do we need that? Do we have to expose the child to that degree of radiation just to confirm that it is a biliary stone, or is an ultrasound scan good enough? Yes, this is enough. Right? This is enough. So the answer should be ultrasound scan abdomen. Right. Last two questions, then we will stop the session for today. 10-year-old girl presented because of poor growth and 4 months of ill-defined abdominal pain. On examination, her height was 128 centimeters. Weight is 22 kilos. She had several mouth ulcers, appeared pale, but examination was otherwise normal. Hemoglobin slightly low. MCV is okay. Platelet count normal. C-reactive protein slightly high. Platelet is slightly low and slightly high, I would say. Ferritin is in lower range. What is the most likely cause of her problem? Right. What do we think? So here, poor growth, abdominal pain, right? Short stature, right? Underweight, mouth ulcer, halo, low ferritin, low hemoglobin. Right. What could be the diagnosis? What could be the diagnosis? Right. Now see, psychogenic pain is highly unlikely, right? Psychogenic abdominal pain could be, could be a possibility when children of adolescent age comes and presents with abdominal pain, complaints of abdominal pain. However, that should not cause obviously anemia, oral ulcers, short stature. No, that is not compatible. Could that be simple iron deficiency anemia? Hemoglobin is low, ferritin is low, iron deficiency anemia is a possibility, but is that the big picture? No, simple iron deficiency anemia should not cause this kind of failure to thrive. And it doesn't cause this kind of systemic manifestations like mouth ulcers. So that is also unlikely. Right? Eosinophilic colitis can present with abdominal pain. However, this would not cause this severe failure to thrive, and mouth ulcers are not classic with them. And then could that be Crohn's disease? Is that ulcerative, or is it celiac disease? We know celiac disease very well. They will present with gluten sensitive enteropathy. They will have iron deficiency anemia, right? And they can have distended abdomen with wasted buttocks, right? However, celiac disease to present at 10 years is slightly unlikely. Child was exposed to starch all throughout, so we usually expect them to present early. But having said that, celiac disease can present later as well. However, celiac and mouth ulcers are not compatible, right? That is not compatible. Celiac and iron deficiency anemia, yes, they have malabsorption, so they might not absorb things. So most of these features are compatible with celiac. However, if you are to argue between celiac and Crohn's comes as the better answer. Right. Right. This we will not discuss because there's a lot of pictures. Right. This one. Endocrinology. 8-month-old male referred due to non-bilious vomiting. His general practitioner had seen him frequently for constipation over last few months. Examination revealed him non-dysmorphic infant with a weight of 6.8 kilos percentile. So there is failure to thrive. He has a scaphoid abdomen and capillary refilling time in 3 seconds, which means he is dehydrated. General examination was otherwise unremarkable. Hemoglobin normal, WBC normal, neutrophil normal, platelet normal, plasma sodium 154 is high. 154 is high. And then potassium is fine, urea is okay. Urinary microscopy is essentially normal. Urine osmolarity is low here, right? Urine osmolarity normal is like above 400 to 500. They will give normal values, right? Normal values will be given. So what do we have to know here? Osmolarity is, urinary osmolarity is low, plasma sodium is high, right? What does this mean? Child is passing diluted urine, right? Diluted urine. The plasma will be concentrated because of water loss. That is why they have high sodium, right? So what is the likely condition here? Low plasma osmolarity with high sodium. So the diagnosis should be what? Diabetes insipidus. Diabetes insipidus. So this is the diagnosis, right? Then why not chronic renal failure? If it was chronic renal failure, obviously we expect plasma urea to be high, right, and potassium to be high generally, right? So that is not the case here. Diabetes mellitus, have they given blood sugar? I can't see blood sugar. However, diabetes mellitus, if that is the case, we usually don't expect high sodium, right, and low plasma osmolarity. In diabetes mellitus, because of urinary loss of glucose, right, their sugar might have even higher osmolarity. Low osmolarity and diabetes mellitus are not matching, right? Hirschsprung disease, of course, they will have constipation. Electrolyte abnormalities are not there. Renal tubular acidosis, if that was the case, we usually expect some of the other, especially sodium, to be low. Most of the renal tubular acidosis can cause loss of sodium, potassium as well. Here, it is not reflected here. And in renal tubular acidosis, they lose a lot of ions like sodium, potassium. So the urine will be rich with osmotically active substances. Therefore, urinary osmolarity is generally normal, or it could be high. It is not low. Right. Sorry. Last question. Last question. Now, before last question, now, if you are, again, I'm telling, seriously preparing, the immediate next exam is like in May, June. If you have not started working on this, I would say that would be too early. Right? We have to be a little realistic, right? It will be too early. And of course, now admission application window is also closed or closing. I think it's already closed. September exam will be more realistic, right? So the first thing to do is we need to make sure that we have important document for application. It's a good idea to contact GMC and get all these degree certificates and all verified. Then you are ready with the things. Then what you can do, when the application window is open, they only ask few things: the application and the degree certificate, MBBS, certificate. As long as those are ready, you can apply then and there, right? Once you apply, it might take some time to process and all. During that processing time also, you can study. But only thing is, we don't wait to prepare until you admit or apply for the exam or get the admission or approval. That will happen in due course, but take now good few months and start preparing. Then you will be done with, say, if it is AKP, done with AKP, right? Then once that is done, you can go for FOP and theory and science, pass it, right? So then at the end of 6 to 8 months, you are in a position that you have passed one component, right? And then immediate next exam will happen in another 3 months time. Now you don't have to submit any more documents to GMC because you are already a member in RCPCH. So no other verifications are needed. Then soon when the applications are open through your account, RCPCH account, you apply for next one, AKP, sorry, FOP and TAS, pass that. It might take another 3 months. We need to be realistic. We can't pass and get GMC registration tomorrow, isn't it? So that doesn't happen that way. Right? Even if you do club, that's the case. Even the exam takes its own time. You need to be patient. All right. And then, like in, say, if you see, like in another, say, 9 months time or 10 months time, maximum of 1 year time, you are done with MRCPCH theory. Then it might take another 6 months, I would say, to be realistic, another 6 months for you to be ready with clinicals. That needs separate training. So clinicals, you train, and then in another 6 months time, you can pass clinicals also. Once you pass clinicals, right, you need to do English exam, IELTS or OET. With that and this MRCPCH membership certificate, you can apply for GMC straight away. Now, for everything to happen, if we are to be realistic, it might take another 1.5 years from today, right? From today. So if this is March 2024, we are talking about, say, September 2025. September 2025. And then it will take another around 3 months for you to get a job, right? So then, say, December 2025, or in better case scenario, 2026 early, you can work as a doctor in the UK. That's the timeline, right? That's the timeline. Now then we should not be discouraged. Okay, will it be 2026? I thought that I can go to the UK and work in next month. We know that it doesn't happen. I don't think that any of us is having that kind of unrealistic goals. Let's prepare slowly, steadily, right? Time will fly with that. With every 3 months or so, if we have got an achievement, now within this 3 months, I have completed this much of MRCPCH AKP questions. Okay, now I am ready. I'm going slowly towards my goal, right? In 6 months' time, you go back and think, 6 months ago, I only had MBBS degree. Now I am having MBBS and MRCPCH theory AKP pass certificate as well. So I'm improving. And then I'm going to do the next. So like that, in 1 year time, you will look back and you will be having 2 certificates in your personal file, right? And at this point, even you can apply for jobs like tentatively. You are not going to get it, right? But you can say in next this many months of time, I'm going to do MRCPCH clinicals. Then I will get EMC registration. If you have some connections in the UK hospitals, sometimes they will keep a job for you. They will keep a job for you. Okay, you will be keeping a job, right? So there is a trainee who is finishing their exam, right? So we will consider you once you pass. Once you pass, let us know. So that's a stimulus for us to work on this, right? And then in another 1.5 years time, you will say, right, in the March 2024, I did not have any other qualifications than MBBS. Now I have MBBS and MRCPCH. That's an achievement, right? Remember, MRCPCH is not just a exam achievement, but that is a license for GMC as well, right? GMC as well. So therefore, we need to make sure that we work on this. Roughly 1.5 years, 1 to 1.5 years timeline. Right? Even if you do club, that will be the case. Any other exam, that will be the case, right? So while doing that, if you are like more keen, right? Parallelly, you will do what other IELTS or OAT. Then we are ready with that as well, right? Now, is MRCPCH an additional qualification if you migrate to Australia? If it will definitely an additional qualification. It will be definitely an additional qualification. Suppose you are competing with a candidate who has AMC. You also have AMC, if that is the case, I'm telling, right? And then you have MRCPCH also, then you will be definitely shortlisted over the other one. But if you ask, can I migrate to Australia with MRCPCH only? You can't. No, you can't, right? And then after you get MRCPCH, you come to the UK and get into the training to become a pediatrician. Say you put it in that way, right? In another 4 years' time, you will be a pediatrician if you start your training from ST3 level. That is the level that they put candidates who have got MRCPCH completed, so ST3. Then from ST3, if you move forward by ST7, you will be a consultant. When you are a consultant in the UK, will that qualification be automatically recognized by the UK? Not only UK, any other country, most of the other countries, say US, Australia, they will recognize UK consultant pediatrician as a qualification to work in their country also as a consultant pediatrician without any other exam, right? Without any other exam. So that's it. But if you simply ask, can I skip AMC by doing MRCPCH? No, you cannot. Will that be an added qualification? Yes. Can I skip lab by doing MRCPCH? Obviously, yes. Right. One last question, which I have seen. I do MRCPCH, I get GMC registration. Later, if I want to become somebody different, a surgeon, a GP, a physician, you name, dermatologist, can I do that? You can do, right? You have got GMC registration by passing MRCPCH. Once you get GMC registration, GMC will not ask through which pathway did you come, whether it is PLAB or MRCPCH, it doesn't matter. You have that qualification, and then you can do any other exam if you want, and then go through other pathways, right? So GP, whatever, right? So that's it. Right. The last question. Which of following is the most appropriate test to confirm the diagnosis? Now, you know, the diagnosis is diabetes insipidus. Diabetes insipidus is due to deficiency of what hormone? Antidiuretic hormone, right? Antidiuretic hormone, ADH deficiency, right? ADH deficiency. So if ADH deficiency is the problem, right? If you want to prove, now look, all these problems in this boy is due to ADH deficiency, right? What do you want to prove? You give ADH and show that the things are reversing. Now I'm giving ADH. Now urinary osmolarity is getting better. Giving ADH and sodium level will come down to normal, right? Now that is called what? Response to DDAVP or vasopressin. This is the test that we do. When you give DDAVP or synthetic vasopressin, when you give that, if the child's osmolarity gets back to normal, then you know that the problem was ADH deficiency or diabetes insipidus. No point of doing blood sugar because this is not diabetes. No point of doing creatinine because this is not a renal problem. If it was renal problem, we expect at least urea to be high, potassium to be high. That was not the case, right? And then plasma osmolarity. You can check plasma osmolarity, but that is not going to confirm. Rectal biopsy is nowhere relevant here because we are not even remotely suspecting this to be Hirschsprung disease, right? Therefore, most likely diagnosis is diabetes insipidus. So the most important investigation to do is TDAVP, right? So that's basically it.